Good morning. The title of my paper is Ocular Tale of Misfolded Protein. It's a case series of conjunctival amyloidosis. So amyloid protein, we know that it is a misfolded protein. It does not provide any structural support. It gets deposited in the organs and it leads to organ dysfunction. So the current nomenclature of amyloidosis includes primary, secondary, and heredofamilial, which actually depends on the protein that has been deposited. The main concerning factor about amyloidosis as a disease is the systemic involvement, wherein the major organs can get involved and which can be life-threatening. The ocular adnexal tissues, when involved, can eventually lead to systemic involvement. Ocular amyloidosis is just 4% of the localized cases. It can affect any tissues of the eye. And when we review the literature, only a handful of series exists, and the highest one from the Moorefield group and only one from the Indian subcontinent. So the challenges we face with this disease are that it is extremely rare, diverse presentation, there's no consensus on the treatment strategy, and it is a telltale sign of a systemic amyloidosis. So keeping all these things in mind, we wish to add to the knowledge that is existing in the literature and share our experience through this large case series. It was an interventional case series, retrospective, and 16 eyes of 13 patients with a mean age of 49.6 years, and the mean duration of symptom was 41.5 months. Males predominated in our series, and the most common referral diagnosis made was ptosis. And the second most referral diagnosis was lymphoma, that is conjunctival lymphoma. Interestingly, on everting the ptotic eyelid, there was a diffuse mass seen, which was causing the mechanical ptosis. In fact, histopathologically, 3 cases had undergone incision biopsy, and amyloidosis could be proven only in 1 case. So histopathological misdiagnosis was also seen in the series. Subconjunctival hemorrhage was something to note, both in the history and sometimes in the presentation, obscuring the mass. Why? Because amyloid actually gets deposited in the vessels, leading to disrupture, and hence subconjunctival hemorrhage in these cases. So in our series, the symptoms included mass, drooping of eyelid, foreign body sensation, eyelid swelling, subconjunctival hemorrhage, and the signs 100% conjunctival mass, and ptosis was the second most common. The mass could be confluent, fusiform, or polypoidal papule. But what was to note was the color. That is, a yellowish hue could be seen in some area of that mass if carefully looked. Site of involvement, bulbar conjunctiva was the most commonly involved. Multifocal involvement was seen in 50% of our eyes, and bilaterality was seen in 23%. So this is a case I just showed. The other eye actually showed a bulbar and a caruncular mass. This lady was referred after incision biopsy of her right eye for initial mass. The other eye, which was told that it is a senile ptosis, actually had a mass deposited in the upper tarsal conjunctiva. So amyloid deposition was missed actually in the 2 referred cases. So stepwise management plan included making a clinical diagnosis and then treatment options, which included excision biopsy, debulking if it was a diffuse lesion, cryotherapy in the lesions, and for ptosis repair, levator resection was done. What was to note in histopathological examination was the characteristic apple green birefringence, which cleansed the diagnosis. The next very important step is to now categorize whether it is localized or systemic, and a baseline workup has to be done in all cases. For us, in all cases, it was normal, and hence proving it to be a primary localized conjunctival amyloidosis in all our cases. Regular follow-up was done, and only in one where it was a diffuse lesion and could not be treated fully in the first setting, it progressed. So a good result after our treatment. So this is just a review of all the cases that I have presented, the results. So this is the largest series from the Indian subcontinent, the second largest globally. And what I would like to highlight here is, even if we have a very subtle mass, like a concretion looking mass in the upper tarsal conjunctiva, or a bulbar lesion obscured by a subconjunctival hemorrhage, maybe looking like an OSSN, maybe looking like a lymphoma, fornicial lesions, caruncular lesions, if we clearly look at the clinical pointers and some pointers from the history, we can actually clinch the diagnosis, because it is very frequently misdiagnosed, and hence the rate of biopsy that has to be done in these cases is also higher. So mismanagement is also common. This is a very good paper by Damaco, which proves that if the patient is diagnosed with systemic amyloidosis, 11.8% were diagnosed to have ocular involvement. In fact, they say that it was underdiagnosed because they could only review the cases in which they presented with an ocular symptom. So hence this was an underestimation. What I would also like to highlight is, if a localized amyloidosis cases is detected in your clinic, 10% are the chances that it is associated with systemic amyloidosis eventually. 15% with the coexisting malignancy like a lymphoma. On review of literature, I could find these are the most commonly involved organs, and if bone marrow is involved, it has a poor prognosis. But in our series, till now, with the median follow-up of 4 years, none had a systemic involvement. This is a paper by Shields which shows the tests that should be done. In our practice, we follow these lists of tests for all our cases, and a very close follow-up yearly with the tests has to be done because progression is known. So I would just like to conclude that this is a very rare disease, but we can see it, especially if you have a ocular oncology practice. And because of the life-threatening implications, it is important to detect it and hence have a multidisciplinary approach to actually diagnose systemically and to keep them on follow-up. Thank you so much.
Very good cases. Before asking the question, I just request Dr. Nilanjan Chaudhary to please report here. Dr. Chaudhary. No, okay, option. Okay, then next are, just wait, just Abhishek Upadhyay, please, you can just okay. In your case, you mentioned that is earlier it was not detected. Can you highlight some points why it was not detected?
So one was a very common misdiagnosis was a ptosis, which was a mechanical ptosis. So 2 patients actually were referred saying for us that do a ptosis surgery, but on eversion of the lid, there was a diffuse lesion. It was not like a papule or a nodule, but the color could be.
Thank you. Your answer is most of the that's a take-home message. We should evert
the eyelid. Yeah.
In ptosis also we can evert the lid if it is not a congenital one, or that's a take-home message. Thank you.
Yeah. Thank you.